Hello everyone. Now we'll discuss question of neurology. So we have a 65-year-old lady and she has come for follow-up. Well, few weeks ago, she developed sudden onset of right-sided numbness and on evaluation it was ischemic stroke. Well, now the patient feels that her sensation is returning. But she also experienced transient burning pain in the right upper and lower limbs. That can be even induced by a light touch. She is hypertensive and diabetes. She smoked half a packet of cigarette for 30 years. Presently BP is high. There is right hemi anesthesia at the moment also. Motor strength is normal. And most likely diagnosis, what we happened 4 weeks ago was, well, the answer to this question is thalamus. Well, patient likely to have experienced lacunar stroke of the posterolateral thalamus. Why is it so? First of all, we talk about stroke. Even in the question it was written that it is on investigation, the patient developed ischemic stroke. That is understood. Now, we say it is lacunar stroke because the only problem what the patient has is regarding sensory loss. Okay, thalamus is a very fairly big structure, but the posterolateral thalamus part is involved, and it is this part which carries sensation from the spinal cord. Well, this is spinal cord, a very rough diagram. This is the pain, touch, temperature. They enter the cord, they cross to other side and they come to thalamus. And then we have position, vibration, sense. They travel upward in posterior column. This is posterior column. They relay and second order neuron, they come to thalamus. This is the spinothalamic tract. So ultimately pain, touch, temperature, position, vibration, everything has come to thalamus. Thalamus is a relay station. And from thalamus it goes to contralateral parietal lobe. This is left side, this is right side. So every sensation has gone to contralateral parietal lobe. That means if the pathology occurs here, every sensation will go. Okay, and that is done by the ischemic stroke. And of course, the part of thalamus I'm talking about is posterolateral thalamus. Now, isolated lacunar stroke in the posterolateral aspect of the thalamus occur due to thrombotic occlusion of the small penetrating artery, so-called thalamo-geniculate branches of the posterior cerebral artery. Well, this patient has many features which can induce atherosclerosis, hypertension, type 2 diabetes, smoked half a packet of cigarette for 30 years. So there are many predisposing factors for atherosclerosis, and this is due to thrombotic occlusion of the small penetrating arteries. Now, as I told you, ventroposterolateral and ventroposteromedial nuclei of the thalamus transiently transmit sensation from the contralateral side of the body and face respectively. Well, in our case, there is a sudden onset of right-sided numbness is there. Okay. Consequent patient with thalamic stroke in this region often present with sudden onset of contralateral sensory loss involving all sensory modalities, pure sensory, because it has involved only those part of the thalamus which is carrying the sensation from the spinal cord to the contralateral parietal lobe. Now, sometimes thalamic bleeding occurs. Ischemic stroke is localized, but bleeding occurs, then it can definitely, this blood can spread to other part. It can spread to basal ganglia and corticospinal tract in the posterior limb of internal capsule. So now when these are involved, that can lead to hemiparesis because of what? corticospinal tract. Athetosis, why? Because of basal ganglia involvement. So, if the patient having thalamus involvement and now later on getting involvement of corticospinal tract, it is definitely a bleeding problem is there. Okay. But what is athetosis? I have a question for you. Stop the video, write down the answer in your copy. Athetosis refers to slow, involuntary and rhythmic movement of the limb, face, neck, tongue and other muscle. But classically we see in the hands, the finger are also affected with the flexing happening separately and irregularly. The hand move and toes, feet may also experience the effect. Look into this. Okay. Look into this. Finger have different type of movement are there. This is flexing extension like this. This is typically athetosis. Now, thalamic patient has come. And as I mentioned in these, let's say this is thalamus and ischemia has occurred. Now, in due course of time, thalamus functions start appearing again. After, sensory deficit can improve after weeks to months. In our case also, patient had a problem few weeks back and now she has come for follow-up. But patient may develop thalamic pain syndrome, Deadery-Rousey syndrome. What is this? I'm going to discuss in the next slide. But before I proceed further, what is allodynia? Stop the video, write down the answer. What is allodynia? Well, allodynia is a type of pain. People with allodynia can be extremely sensitive to touch. Activity that are not usually painful, like combing one's hair, can cause severe pain. Like in our case also, patients say the slightest touch is causing severe pain to the patient. That is allodynia. Now, what is so important about it? Because now, what I told you, in the patient, in the recovery phase of thalamic lesion, they develop Deadery-Rousey syndrome. This is characterized by severe paroxysmal of the pain over the affected area, severe pain, over the affected area. This classically exacerbated by slight touch, and this is so-called allodynia. So now imagine patient feel intense burning sensation, even slighter touch can cause pain. So we can classically say allodynia occurs in thalamic pain syndrome, so-called Deadery-Rousey syndrome. Now let's look into other option. Can it be internal capsule infarct? They have choroidal pure motor or combined sensory motor. Why? Let's learn the anatomy. This is the posterior limb of the internal capsule. This is the anterior limb. Most simplest line diagram. This carries motor fiber. This carries sensory fiber. Motor fiber are going down and sensory fiber are going up to the parietal lobe. These are supplied by deep penetrating artery. If this artery involved, it will lead to motor problem. If this artery involved, it will lead to sensory problem. Both can also be involved, and it will be motor and sensory. So disruption of the corticospinal or somatosensory fiber in the posterior limb. But central post-stroke pain is not a feature. The thalamic syndrome or Deadery-Rousey syndrome, where the pain, burning sensation of pain appears after few weeks, is not a feature that we see in internal capsule lesion. Similarly, lateral medullary syndrome infection occur due to posterior inferior cerebral artery, so-called pica. And that's why this is also known as pica syndrome. Well, I have a question for you. Write down the answer in your copy. Pica is a branch of which artery? Stop the video, write down the answer. Answer is vertebral artery. Well, now patient having this lesion, patient can develop lateral medullary syndrome, pica syndrome. Let me tell you what happened. This is the anatomy of the medulla oblongata. This is inferior inferior cerebellar peduncle. Okay, this is the 10th nerve nucleus, 8th nerve nucleus, 5th nerve nucleus. Then this is the sympathetic chain, and here is the spinal lemniscus. This carries pain touch temperature from contralateral body, pain touch temperature from contralateral body. Now this part of the brain is supplied by pica. So if the pica is gone, say this is on the right side, this is left side, so there will be right-sided cerebellar feature, right-sided 10th nerve lesion, but since, and then 8th nerve lesion, but and 5th nerve lesion, that will be ipsilateral sensory loss on the sympathetic chain, Horner syndrome, contralateral loss of pain, touch and temperature. So let us see. So there is loss of pain, touch, temperature over the ipsilateral face, and contralateral body due to spinal trigeminal area and spinothalamic tract lesion. Point to be noted, face on one side and body of the other side, sensory loss is there. Ipsilateral bulbar weakness, nuclear ambiguous, vertigo and nystagmus. 8th nerve nucleus, Horner syndrome, sympathetic fiber, cerebellar features that I showed to you, all are a part of lateral medullary syndrome, and this is also known as Wallenbach syndrome. Midbrain usually comes with ipsilateral third nerve palsy and contralateral hemiparesis. Well, let me show you the diagram also. These are the corticospinal tract. This is third nerve, and this part of the brain is supplied by posterior cerebral artery. The structure involved are, this is right side, this is left side, third nerve and the corticospinal tract. There will be ipsilateral third nerve palsy, contralateral hemiplegia. This is so-called Weber syndrome. So this is what we get in midbrain lesion. Putamen will lead to hypertensive. Putamen is the most common site of hypertensive bleed. Okay. Internal capsule lies adjacent to putamen, is always involved. Internal capsule is involved, and as I mentioned in the previous slides, it lead to hemiparesis because of involvement of corticospinal tract, contralateral sensory loss also, and conjugate eye gaze palsy. That means eyes, they see toward the lesion. That is classically we see in putamen bleed. Okay, but again reminding you, putamen as such is not a cause of this problem. Putamen is a part of basal ganglia, but it is all feature occur due to involvement of nearby internal capsule. The golden line to remember: lacunar stroke of posterolateral thalamus, typically present with sudden onset of contralateral sensory loss involving all sensor, pure sensory stroke. Week to month later, they can come with thalamic pain syndrome. It is characterized by severe modality pain, paroxysmal burning pain over the affected area that is exacerbated by even light touch, so-called allodynia. Thank you very much.